Am I being hormonal? Darn right I am. Hi, everybody. This is Dr. David with another episode of Your Health, Your Choice. And we're going to be talking more about hormone therapy and when good times to initiate hormone therapy, when to talk to healthcare providers, some of the risks and benefits. Another episode here. This is actually part 2 of a 3-part series. And if you haven't seen part 1, go back into our history and you will certainly find that. And today we are again welcoming Dr. Cathy Nutting, who works for us for the last 7 years at Holistic Pediatrics and Family Care. Hi, Cathy. It's nice to see you.
Hello, Dr. David.
Yeah,
How are
and if you
you?
missed, I'm doing great, doing wonderful. So if you missed our original introduction, a little bit about Cathy. She's a family nurse practitioner. She's board certified in anti-aging and regenerative and functional medicine. She holds a Master of Medical Science, Nutrition, and Metabolic Medicine, and a Doctor of Nursing Practice. So not just a nurse practitioner, but even got an advanced degree of which she actually trained in our office as part of that, which was
Right,
kind of cool.
exactly.
And she actually put together the program at University of South Florida as well for this. So she talked about
Mm.
a real just start off kind of person who's going to go out and get what she needs. That's Cathy Nutting for you. So, hey, Cathy.
Thank you. Hi. Yeah, you joke
Yeah.
about, hormones. A lot of people joke about hormones. There's so many jokes about hormones. Hormone, like menopause is like a volcano with sweat, and everybody, instead of lava, and everyone runs, for their lives. Or, PMS, I hope this is, not is actually, I hope PMS is actually real instead of my personality, right? But these are symptoms that are really severe that with people, and they affect relationships and lives. And a lot of people, have stereotypes about hormonal related symptoms. And a lot of people think, that's, we just have to deal with it. It's that time of life, or it's just something that happens around the time of my period and those kind of things. But that's not really true. There's lots of things that you can do about it, right?
Yeah, absolutely.
Yeah.
Absolutely. So, and this is a very complex subject. I know you've heard me
Mm-hmm.
talk about things like vitamin D and zinc. You check your levels, you get them up, wonderful. Boy, that would be so nice if that is the way that we could handle our hormones. But unfortunately, it is so much more complicated than that. So we're going to be talking about a few different aspects. And one of the things that I wanted to touch base is on the genetics of it. Okay.
Yeah.
So obviously, all substances in our body, they don't show up there magically. There are genes that code for the production of them. And then how are those genes being turned on and turned off, the metabolism. So Cathy, if you can talk to us a little bit about how our genetic makeup can have some impact on the hormones that are being produced and utilized.
Yeah, so exactly. So, one of the things that is really important when you're having those risk benefit discussions with patients that are having hormonal symptoms, and you're evaluating the different treatment options is, what is their genetics related to hormones, related to kind of the treatments that you might be considering. And in regards to estrogen, we have some really good tools for evaluating if people have increased genetic risk for poor estrogen metabolism. And we, in our office use a genetic SNPs test called the Max Genetics Functional Test frequently. And that has on that report, it reports, if patients have those kind of difficulties, getting rid of estrogen out of your body, which can make your kind of estrogen progesterone balance, it can exaggerate that, even if it isn't, even if the numbers don't look like they're out of balance. If you're having trouble, if you're holding on to excess estrogens, it can be a problem still. And so there's lots of things that can be going on genetically, and other genes too that interact with the estrogen related genes that can be a problem. So the MaxGen report kind of gives us a snapshot into if that's something that we should be on the lookout for.
Yeah, absolutely. Now, one of the things that I know and that you helped create for us was a symptom checklist, our
Yeah.
holistic pediatric and family care hormone symptom questionnaire. Okay.
Mm-hmm.
And I know that based upon the symptoms that people report to you, that right off of the bat, that can start pointing you into some certain direction. So can you give us all
Exactly.
some examples of like what would be like a couple symptom or a symptom complex that would make you think one direction versus another?
Yeah, so a really common symptom of low progesterone, which is a really common problem in women, is trouble sleeping, anxiety, even depression. But, big ones are really trouble sleeping and anxiety. Irregular periods, that's, a big one with progesterone. Yes. And then, of course, a lot of people know things about estrogen, like hot flashes or vaginal dryness, those kind of things. Yeah, and a lot of people, associate, low testosterone with libido, but it also affects, energy and cognition and so many other things. So does estrogen. So there's really a lot of hormonal symptoms. And the symptom questionnaire not only allows me to kind of identify those things, but I score them. And then so I can trend it over time. So I can really evaluate if people are getting better or not, or if their symptoms are getting worse, or something has changed. Because over the course of our lives, our hormones, as women in particular, change quite significantly.
Mm. And you mentioned before about, assessing risk versus benefits. So
Hmm.
what are some of the risks that may come into account here that would make you take pause in doing something?
Yeah. So, if you have trouble metabolizing estrogens, before we would give you some estrogens, we would want to kind of shift your estrogen metabolism so it was be more efficient, right? And we can do that with supplements, we can do that with diet. Also, some things that you consider when you're doing kind of a risk benefit analysis: is there a family history? Is there a family history of hormonal related, cancers? Is there family history of heart disease? Is there family history of osteoporosis? Is there actual personal history of those things as well? So those things take into account history. Have they had normal kind of screening exams? Have they had, nodules in their breast? Do they have fibrocystic breast? Those kind of things are really kind of a lot of the things that we take into consideration. And then also, the severity of their symptoms and their, what their, personal choice is and their beliefs about what they want to do, and what is important for them going forward in life. Is it more important for them to have a sharp brain, or is it more important for them to, avoid, risk of any potential complication, at all? Do they have coagulation genetics that could be problematic? Do they, and you can, modulate some of those things. Not some of those things, increase risk. Some of them don't. Some of them are modifiable. Some of them aren't. So we really have a pretty detailed conversation about all those things, and then, then our well-educated patients make decisions for themselves, right? So we
Right.
provide them information about choices and real, risk and benefits. And we give them some information that a lot of them don't really know about, because a lot of people think, oh, well, the Women's Health Study showed that there was an increased risk of breast cancer with estrogen. And that's actually not what the Women's Health Study showed, because the estrogen only arm of that study showed a reduction in breast cancer, and they followed those patients for 11 years. The part of the arm of the study that caused increased risk of cancer was the progestin arm, which, if you remember from our last episode, is non bioidentical progesterone, right? And so that's not the kind that we typically recommend, and people don't choose that, because we talk to them about the differences and the different risk ratio. Also, there's differences in how they react in your heart, and cause vasospasms, where kind of the natural sources, or the bioidentical sources, don't.
Gotcha. Gotcha. Now, I know that one of the things that you have to take into consideration is not just picking the right product, but how it is given. So, talk to us a little
Right.
bit about
Yeah.
the different ways that that the different hormones can be given, and why you may choose one form over another.
Exactly. So, in regards to progesterone, The route of administration that I typically choose or we discuss with patients about has somewhat to do with their symptoms. And because oral progesterones tend to have a better effect on anxiety and sleep than topical estrogens. So some people have a preference just in the form, how they do it. With topical progesterone, we can mix it though with estrogens if we compound it. So there can be a cost issue related to that with having more than one compound. So sometimes we'll do it that way. Sometimes people just prefer to not take capsules, or they have some, GI irritation, or they're already taking so many other capsules, so they don't want to do that. But I find that I use a lot more oral estrogen because of the fact that I've been able to get so many women off Xanax and sleeping pills and anti-anxiety medicine and all, a whole list of medicines when you actually treat the cause of their problem and use bioidentical forms of progesterone. In regards to estrogen, I think the route is more important as far as risk, and there was studies that showed that that topical routes of hormones have less risk of hormone related complications like cancers, and hormones don't cause cancers. In some conditions of breast cancer, they can make them grow faster, but like I said, from the largest study that's really ever been done in patients that were only taking estrogen, and these weren't even bioidentical estrogens, there was a reduction in breast cancer. So yeah, and the people in the study who took estrogen versus who didn't take estrogen had less cancer in general in that study. So yeah, so I
Gotcha.
think there's a lot of misconceptions about that. And before kind of the women's health study, there was kind of a big trend that everyone should be on estrogen, right? Because it reduces cardiovascular disease, and that's what the study was originally designed to show, which it did show that, just not for progestin, right? So that's one of so we kind of clarify when we're talking about risk and benefits with patients, some of the misconceptions they have about the research or the literature or the just publicity that's been around hormones, and talk about their individual risk. Like, do they have osteoporosis? Are they having cognitive decline? Do they have family history of cognitive decline, of cardiovascular disease, of breast cancer? Or have they personally had breast cancer? But it's safer to give hormones, estrogen, topically or vaginally. It's metabolized better. Oral estrogens go down a non-preferable pathway of metabolism,
Hmm.
which we can
Now,
see on Dutch testing, right, or
yeah,
on metabolite testing.
yeah, and we're gonna move into testing now. Now, really, the first time that I started getting involved in some of the female hormones, and as some people know, that that we'd come up with this idea of the Preconception to Infancy Project (P2I). The paper that I originally published is now 10 years old. I've been thinking it may be
Yeah,
time to
wow.
publish a new article on that, so
Yeah,
maybe our 10-year anniversary in that. But one of the things, and especially in women who have had a lot of miscarriages or had miscarriages,
yeah,
is that some women do not make enough progesterone when they first have
correct.
their
Yeah.
conception. So
Mm-hmm.
progesterone promotes gestation. Neat name there,
Mm-hmm.
huh? And so one of the things that we do, that we've had that problem, if we've seen this problem in a woman, is as soon as they're pregnant, as soon as they have their
Yeah,
first pregnancy test, we'll
sure.
not only send them for a beta HCG, which is the number that keeps them going up during pregnancy, but we check a progesterone level. And if the level is not where we want it to be, we will give progesterone in a vaginal suppository form, kind of getting it right as close to the source as possible, and then we follow it along. And a lot of times
Mm-hmm.
we'll keep this going until towards well through into the first
Mm-hmm.
trimester. At some point,
Yeah,
the body picks up on its own, but to kind of give that little bump,
exactly.
keep
Exactly.
the uterus lining getting it thicker, plumper, accept that zygote, and to be able to give
Mm-hmm.
enough nourishment to that to grow. So that's really kind
Yeah,
of one of the areas that
right.
I had gotten into. Now,
Yeah.
you had talked a little bit, and I know we just have a few more minutes left on this segment, but we had talked a little bit, about like Dutch panels and lab panels. So I know that there's different ways of doing hormone tests that so let's first talk a couple of seconds about, when people can get lab testing through Quest and LabCorp and not, on their insurance lab. So when is it
Yeah.
appropriate to do a test, one of those versus some of the more advanced panels?
Yeah, so you can usually do baseline testing through serum labs. That's appropriate. Dutch, you're really looking more at risk and hormone metabolism, and saliva testing. You're looking at levels, and sometimes we get saliva testing just because it's more cost effective than even like our client billing that we use for paying patients. So that's another reason to do that one. Yeah, and we do, like I said, for the pregnancy labs, those are serum labs, right? And how
Right,
many
right.
how many people who couldn't get pregnant before in our practice miraculously have babies now? That's, amazing. I think one of our big accomplishments,
Yes, bringing
right?
good, healthy
Yeah.
babies into this world,
Yes, exactly.
giving them a hospitable host uterus is what I like to talk about. Having a
Exactly.
hospitable uterus there, and okay, and also I know that 1 day testing versus month-long testing, and obviously month-long
Sure.
testing is going to be the most informative if a woman is trying to track her cycle, if she doesn't have a very typical type of what's a 28-day,
Yeah.
30-day proper there. But
Yeah.
if a woman is all over the place, if she may be having some breakthrough bleeding, other types of things that can be a much more helpful thing to look at it throughout. So really, this again something that we can't, one shouldn't be dabbling with. Certainly something that really a person can't be doing on their own. If a person can
Yeah.
send in a vitamin D level and again check that, but don't be dabbling when it comes to all these different hormones because you can kind of get messed up if you don't get the right dosing or the right form of it. Now, the
Yeah,
last
we've
question I
seen that
have for
too.
you, yeah, is when should a woman start to talk to her healthcare provider relative to menopause and kind of helping through that part of her journey?
Yeah. What I think is more important than menopause or postmenopausal hormone treatment is perimenopausal hormone treatment, which is usually ignored, right? So, for 10 to 15 years before your estrogen declines, when most people kind of start talking about hormones when they start having hot flashes and vaginal dryness and kind of their, brain fog and those kind of things, already for 10 to 15 years, their progesterone has been declining. And that's really when we can affect risk more because that estrogen time when that estrogen is high and the progesterone's low, that's when we, develop heavy irregular periods. We get cysts in our breasts. We get, trouble sleeping. We get anxious, all those kind of things. So you really should be starting before that. And then I think that's really important for people to know. And then certainly any time in the course of your life when you're having hormone related symptoms, I usually don't have a problem having people come and ask for help when they're in postmenopause or going through menopause because that's sort of the society trend of when to seek out help for that. But the time before that is really kind of, I think, more critical.
Yeah, that makes a lot of
Yeah.
sense. All right,
Yeah.
well, there you go. There is the end of episode 2. Thanks again,
Awesome.
Kathy,
You're
for
welcome.
taking time with us.
Thanks for
Again,
having
this is
me.
the third. This is episode 2 of a 3-part series. And so, if you didn't catch episode 1, catch that. Episode 3, if depending on when you're watching this, is out there already, or it will be put out there soon because we're actually recording them all on the same day. But 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 obviously we wanted to get this information out to everybody. We think it's an important thing, and of course, recording this during Women's Health Month, what better time to be recording it? So, thank you so much. Of course, everybody hit us up on our, subscribe to this channel, all the stuff you hear me talking about. Hit the notification button, join us on Patreon, etc., and have a great day. Bye bye. Bye, Kathy.
Bye.